Hi, this is Rusty Rhodes coming to you from Atlanta. I had the privilege of serving as the chairman of the section back in 2005. Just a couple brief ideas. When I first started going to the section back in the early 90s as a senior resident, the meetings were obviously much smaller. The practical courses were quite simplistic. I remember courses on halo application and interspinous wiring with stainless steel wire. We certainly have come a long ways. And as neurosurgery started delving further and further into instrumentation as the technological tsunami took off, I remember the time where there were battle lines drawn between orthopedics and neurosurgery in this country. Locally, at the national level, we were all fighting some battles for privileges to do this type of stuff. And it was really the pedicle screw litigation that brought those walls down. And the section provided a lot of input to the national organizations and the U.S. government, legal teams. And I think there was an exciting time because it really brought us and our orthopedic colleagues together to now have the meetings that we have today, where we have terrific talent teaching all of us from both specialties. And I consider it a great privilege to be a member of this organization. Every meeting is a fun reunion with my favorite people in neurosurgery. And every year, I take a long list of things back with me to my practice to change things and try to do things a little better. And so I look forward to it every year and look forward to seeing all of you in Las Vegas. Thanks.
Please welcome moderator, Dr. Erica Bisson.
Good afternoon. So exciting to be here today. I want to again congratulate Eric and Zach and Charlie for this amazing meeting. I've heard over and over again throughout the last few days at the enthusiasm and energy going on in this meeting, and I think it's palpable and super exciting, so congratulations. We are going to start with my slides. There we go. Welcome to the Cahill debate session. This is one of my all-time favorite sessions that we have during our Spine Summit meeting. It's a time where brilliant minds get together, show us the data, and then help us understand how to best treat our patients. So I have the pleasure of starting the debates, looking at arthroplasty versus ACDF, and again, two brilliant minds, both past chairs of this session. So here's the case, Zoe and Dom, 30-year-old male with left shoulder and arm pain. This has been going on for several years, also has some periscapular pain that radiates to the posterior arm and forearm. Pain's constant, worse with activity. His symptoms have been worse since he had a motorcycle accident in 2020 where he sustained a left bicep and radial nerve injury. He had some improvement in his wrist drop early on and hand grasp, but he still has significant loss of function. He's failed to improve from extensive PT with home stretching program and multiple medications. Here you can see his exam. He obviously has some muscle atrophy because of those injuries. His tone is normal. He has no spasticity, some decreased range of motion. And his strength is nearly normal except for 5- in elbow extension, and again, the 3/5 in wrist extension. He's got decreased sensation to light touch throughout his left hand, forearm, and biceps, and is areflexic in the bicep brachioradialis and triceps are 1+. Here are his flexion extension films. And here's his MRI. So now we will hear the two debate what's next. We'll start with Dr. Dom Korick.
Awesome. Thanks, Erica. And this is my disclosure of note. There is nothing related to cervical arthroplasty. I don't get anything for cervical arthroplasty. I've got a couple of ACDF fusion types of things floating around up in there, though. So what we're looking at here is not really a debate in some theoretical sense, is arthroplasty better than ACDF? Is arthroplasty going to replace ACDF? Those are at best moot and at worst counterproductive. The reality is what is best for this particular patient is not in some philosophical sense. ACDF is the greatest operation and can never be challenged. So what we're looking at here is, and again, I want to thank Erica, not just for being awesome in general, but for picking the perfect case for arthroplasty, because there are some things about the patient's history that make not straightforward, but it really is a straightforward case. At the end of the day, the patient has a foraminal disc and has radiculopathy. Yes, there's some trauma. Yes, there's some chronic stuff going on there. But don't let Zoe obfuscate the matter here. This is a case of a foraminal disc with cervical radiculopathy in a young, active patient who has focal disease, really one-level disease, early spondylosis, not collapsed down. There's still motion preserved at that level, good sagittal balance, a foraminal soft disc, and again, isolated anterior disease we didn't see all the films in a CT scan, but there's no obvious facet disease. So this is the ideal patient for cervical arthroplasty. And in fact, it literally defines the ideal patient for cervical arthroplasty. And ACDF is not only not the first choice, it really shouldn't be amongst the first several choices. I would say that cervical arthroplasty, number one, posterior cervical foraminotomy, number two, endoscopy, probably number three, and then ACDF. Why? Not because ACDF is some horrible operation. It's a great operation. Done it hundreds, if not thousands of times in my career, and it will always be there for cases that we talked about, kyphosis, instability, tumor, trauma. It is not going to be replaced by arthroplasty, except in the case of young, healthy patients with isolated disc disease, anterior disease, without multi-level disease with maintenance of motion. So what we're looking at here, why? Because number one, the patients do better from a neck pain perspective, because it turns out the discs are there for a reason. They're there to facilitate motion, and the primary thing that ACDF does is stop motion. So a very unnatural phenomena. It should be used in cases of instability or tumor, trauma, et cetera. And two, adjacent level disease. We know adjacent level disease is multifactorial, but it's real, and the reoperation rate is probably somewhere around 1 or 2% per year. So in this particular age patient, he's looking at an 80 to 90% chance, 80 to 100% chance of reoperation over the course of his life. Here's Hillebrand's seminal paper, one of the most widely quoted and misquoted papers in the history of spine surgery. But when you look at the adjacent level actual reoperation rate, about 0.7%, rounds up to about 1%. So it's fair to say 1 to 2% rate after ACDF. Again, in this patient age population, he's going to get another operation. So why, if I don't have a dog in the fight for cervical arthroplasty, why am I pleading with people to do an operation that is going to pay me about 30 or 40% less than I get with ACDF, an operation that I've loved since I was a resident, and an operation that has been around for a long time? Because it's not best for my patient. It's not best for this patient. Why do I say that? I have an experience with 10 IDE studies, over 200 patients in prospective randomized level 1 trials. Now with long-term follow-up, I did my first arthroplasty in 2001. Patients still come back to see me at literally 15 to 20-year follow-up. So you say, that's fine. That guy doesn't know what he's talking about. There's something else going on. There is bias. There is a huge conspiracy for the companies to want to sell artificial discs, and I've bought into it despite the fact that I'm going to get paid 20, 30, 40% less. And that conspiracy now involves 5,000 patients, over 300 study sites, and literally thousands of investigators. That doesn't make bias go away, but it minimizes to a huge degree. So there is an unprecedented amount of level 1 data. In fact, more level 1 data support arthroplasty than there is support ACDF. And ACDF gets its data from these studies as well. So again, this is something that for this particular patient, healthy patient, central foraminal soft disc disease, this is the procedure of choice. If you don't agree, I'll let you listen to the Tyrannosaurus Zoe coming up here to talk about it. Thank you.
All right. So I guess first thing is it's a real honor to have a chance to share the stage with Dom, who is, I think, undoubtedly a world expert on arthroplasty. But I'm going to do my best. I have no real disclosures that are relevant here. But I think that it's important that, as Dom says, that this is not a philosophical debate between arthroplasty and ACDF. There have been a lot of randomized controlled trials, and we're not here really to debate that. The thing which I agree with Dom is that this is about this particular patient, and that's what I want to focus on. So really, I think all of us in our office every day look at individual patients, look at their individual story, their individual anatomy, and try to come and use our best judgment to figure out what the right thing to do is. In today's case, this is a young guy, 30 years old, with a chronic neck pain and radiculopathy, previous left biceps and radial nerve injury. So this is not a simple soft disc herniation at one level, creating all of his symptoms. He has a foraminal disc for sure, but that's not all of what he has. And so we've got to really think about this as an individual case. If you look at his physical exam, also, I think it's very clear. He's got some long-standing evidence for radial nerve injury that will not disappear. He's also got more than just a pure C7 radiculopathy in this case. His flexion and extension images, as Dom showed, they look good. There's good motion there. He's a young 30-year-old, so no real problem there. But this is more than just a simple case. And the MRI here shows a foraminal disc with compression of the left C7 nerve root. If this was all he had, I think I would strongly support an arthroplasty. I think that's a good operation for him. But this is a patient who's going to have ongoing symptoms afterwards, and you want to really know that you've done an operation that you understand the long-term ramifications of, so that there's no question or issue about that procedure being related to any of his ongoing symptoms. So who's the ideal patient? As I said, we've had 8 IDE trials. We've had, as Dom says, 5,000 patients involved in multiple randomized control studies. So a lot of evidence to support that patient-reported outcomes are better in patients who have a single-level soft disc herniation with unilateral radiculopathy. That's not really the question. But when there's neck pain, when there's instability, when there's facet disease, this is not the population that was in these clinical trials. And so I think this particular case is not exactly the type of patient that was included in those randomized studies. The other thing that I think we need to focus on is that we have great patient-reported outcomes and we have great trials, but we don't have as much information as perhaps we should on the long-term complications associated with arthroplasty. A lot of these that you see listed here, vascular compromise, dural injury, infection, dysphagia, all also seen with ACDF. But some of the long-term implications of cervical arthroplasty have not been fully understood. Implant failure, 7.8% at 10 years, and adjacent level surgery, while many meta-analyses suggest that it's lower than ACDF, it's not eliminated with arthroplasty. There's also been a number of meta-analyses that have questioned whether the long-term adjacent level disease is really different from ACDF versus arthroplasty, and we should keep that in mind. And there are multiple reports of migration of device and so forth, although rare, are certainly things that we need to figure and into our overall decision process. What about commercial bias? Tom Mraz wrote a nice paper looking at complications and papers that had looked and evaluated complications and found that when there was conflict of interest amongst the authors, they were less likely to report the complications associated with cervical arthroplasty compared with papers where there was no commercial bias. And so I think we've got to make certain that we focus on this. Last, set of points here is the long-term implications of cervical arthroplasty. We know that half of these patients have heterotopic ossification. We know that 1 out of 3 patients has implant subsidence, and also there's an increasing focus on osteolysis as a complication of patients who have cervical arthroplasty seen in the long term. So I think for a 30-year-old patient, I would consider what we know works best, and we know what we do. I looked at the cervical spine registry. 62% of cases in the registry are ACDNF. So I think ACDF is here to stay. It's a good operation that we understand, particularly in a more complex patient. Thanks very much.
Thank you to Zoe and Dom for those incredible arguments. We are going to put up the Slido so that you can all vote and decide if Zoe is truly a Tyrannosaurus Rex, maybe, or a Brontosaurus, or if ACDF is a tried and true operation.
It's a throwdown.
It is. Great audience participation, great room. Oh, we'll give it a little countdown. 5, 4, 3, 2, 1. We'll declare Dom the winner.